10 o'clock in the morning. Good morning, Victoria, and good evening, Europe. So today we have a pleasure of having Dr. Kushniruk, who is the director and professor of the School of Earth Information Science, University of Victoria. He's truly a multidisciplinary person. And he's just like a cocktail, if you like. He's got psychology, biology, computer science, and cognitive science, cognitive psychology. So he's got a mix of it. And I think he's done mathematics as well. So he's got truly a multidisciplinary. And he conducts research in several areas, including evaluation of effect of technology, human-computer interactions. He's a world, he's known internationally about human-computer interactions, usability engineering. Dr. Kushniruk research focuses on developing new methods of evaluations of information technology, conducting video analysis of the computer usage. And he's got enviable sets of publications, over 300 peer-reviewed articles, many books and editorial books, and so on. So I don't even have one. So there you are. So it's a pleasure to introduce him to give a lecture on cognitive and human-computer interaction, which is his love in this area of research. What is the role of cognitive research in health informatics? Andre, take it away.
Okay,
thank you.
Thanks. Yeah, thank you. Yeah, this is one of my favorite topics. Goes back for me a long ways. I mean, I began by the sort of what is cognition and why is it important in general and cognitive science, and then I'll get into how I've been using it and how I think that area will evolve over time. So here in cognition, the focus is on understanding intelligent behavior and thinking. And that could be by humans and machines, which is why I always like working in the area, right from graduate studies in the area known as cognitive science. So what is cognitive science? It's a broad field that borrows from many areas. Cognitive psychology is a core, but also computer science, philosophy, AI, anthropology, linguistics, human factors. It's kind of an amalgamation of inputs from many different areas. And the idea is the focus isn't just on human, but also machine intelligence. So it's really, I think, time for a resurgence in this area because of that. So what does cognitive science focus on? It's aspects of human and machine cognition. So what are the areas that are covered include reasoning, how we reason, and I'll give some examples today of how we've applied looking at human-computer interaction in terms of impact on reasoning, decision-making, how we learn or acquire knowledge. So knowledge acquisition is another area in this umbrella. Perception and attention also fit under cognition because that's how we get information that we process. Human and other memory is another subtopic area, learning and learnability, and generally how we solve problems. So you can see it's a fascinating area that covers many other areas that are brought into this. So let me just go to the next slide. And it's not a course in cognitive psychology, but I do want to present some models that occurred over time that have been influential in the whole field of cognitive science, human-computer interaction, and hopefully today you'll see how we brought some of this in health informatics. On the right-hand side is a model of cognition that is an old model. It's from the 1980s initially. That's the head on the right-hand side with different boxes in it, like working memory, a perceptual processor, cognitive processor. This was a going idea at the time, is that the human brain is like a metaphor for information processing, human information processor model, they called it. And you can see the focus is on different stores, memory stores, and processes in the individual decision maker or person reasoning. So that was a model that was predominant for a while. And then over time, as we'll see, on the left-hand side is the model called distributed cognition. That in reality, for solving any complex problem that there's probably more than one person involved, there are probably now computer systems involved, and there are representations of knowledge and information on paper, on computer, on smartphones. And that collectively forms sort of, if you want, an understanding of how decisions are made. So in this article, we just kind of glued together to say it's not one or the other, but that we will look at both of them. And I'll show you how we've operationalized that today for looking at health information technology. So cognition and usability. I've always looked at usability from the perspective of its relation to cognition. So what is usability? We'll say it's ease of use of the system in terms of the number of aspects. And we can see the aspects have a relation to cognition. Learnability, how easy or not is it to learn how to use the system? Effectiveness, does it do what the user wants the system carry out the task it's supposed to do? Efficiency, does it do it that it takes 10 mouse clicks when it should only take 5? User satisfaction or their perception of how they feel about the system, and last but not least, the safety. And I'll talk about how these dimensions can be used to design studies that focus on one or more of them. So I think it was quite advanced when they started looking at usability in terms of dimensions. And there's also international standards definition I don't have on the slide, but it's very similar in the way. And the other thing I'll just note is that many of you have now heard the term UX or user experience, and a fair amount of overlap. I tend to look at usability broadly, including how people feel about the content in that, and that's often considered now under UX, but very similar concepts. But the argument is that understanding the impact of the above on cognition is going to be critical in health informatics, and I'm going to present that argument as I go along. So further background, since we're talking about a number of different areas, is human-computer interaction. My favorite definition of this is from the Association of Computing Machinery, that human-computer interaction, or HCI, is a discipline concerned with the design, evaluation, and implementation of interactive computer systems for human use and the study of major phenomena surrounding them. So it's a very broad area, and as you can see, cognition is central to will be central to understanding human-computer interaction. So I've applied an approach since the 1990s called usability testing, and I've looked at it as an approach that can study both cognition and HCI, as the two are related. I'll show you what I mean. And usability testing is the most established method for usability evaluation and is central to human-computer interaction research. It can be applied throughout the whole system development lifecycle, and we can use it, and I'll show examples for assessing impact of systems on human cognitive processing, and providing feedback into designing, implementing, customizing, and I think I will also mention a few examples in system selection. So the idea is cognition comes into this because the idea is to create a better fit of the IT systems into the health professionals' thinking processes and work processes, which is the spin or angle I've always been applying. And something I've worked with for years is called Think Aloud Protocol Analysis. And this goes back to a seminal book by Erickson and Herbert Simon. It was 1993 on Think Aloud Protocol Analysis. The idea came from cognitive psychology and was used in many different types of studies of human problem solving, everything from chess to medicine, physics. And the idea is we give a person a task to do, and then we might observe what they're doing, whether it's solving a physics problem or playing a chess task, and we have them verbalize or think what's going on as in their head as they're doing it. We ask them not to theorize about what they're doing, just essentially to give a memory bump from what's known as a working memory, the memory that's in their head at the time. So this proved very useful in many studies of human expertise, which is one area it's been used, problem solving. And when it was applied, I applied it early 90s, and it only began to be applied then for computer studies, where we have someone sit down with the computer, do a task. We can record what they do, but we also want to know what they're thinking at the time, so we can relate the two. So this proved to be very useful and has now also become a mainstay in usability testing work. One other thing, and what I'll talk about, some examples. I always like examples, but give some background first. But I'll talk about a number of different, what I call cognitive studies that we did. And they range on the continuum. On the left-hand side, if we give someone an artificial task to do and ask them to think aloud while they're doing it and record them, we can either do that in the laboratory or not. We could do it in someone's office, as also. But I look at that as kind of laboratory style study, because it's not the real world, it's artificial, but we can get a lot about what's going on in the individual's head using a system. In the middle, I located simulations, and we'll talk a bit about doctor-patient computer simulations. That's getting more realistic, but it's still controlled studies. And then on the far right are in situ, where we look at observing people using systems in the real setting, could be naturalistically, could be remotely, and we get into all kinds of interesting techniques like automated analysis and data mining of user logs. But I would just say that there's a whole continuum of studies where we can apply a cognitive approach. And we may start on the left-hand side and then move over, get some more data, come up with some conclusion about how a system will work in the real world, and then have to go back and test something in the lab again. So it's a fluid continuum. So why I did this talk on this topic is because I've been thinking back on the role of cognition and HCI in health informatics. Recently been working on, this book will come out shortly, on editing, re-editing of a book that came out a few years ago in cognitive informatics and biomedicine, human-computer interaction in healthcare. So with the new edition, we're actually subtitling it Cognitive Approaches. And the argument we're making is that to build effective systems in healthcare or any other complex domain, an understanding of cognition is needed if we want to develop systems that fit the user needs and their cognitive processing, and that, for example, don't inadvertently overwhelm or alter successful human patterns. So the argument will be that we have to have cognitive studies in order to achieve those two objectives. So, as I said, this book will come out shortly. In doing what I've been working on, we use what we call cognitive coding to understand human-computer interaction. And a range of approaches, as I've mentioned already, this involves usually observing people carrying out tasks, which in human practice is known as task analysis, and video coding those interactions, which is an area that I've focused a lot on. And those interactions could involve individuals, as in the human information processing model I showed on the first slide, the second slide, but they also may involve group interactions, which is more like distributed cognition in the clinic. And we'll look at how we can tease those apart. And I've always promoted that you don't need a $1 million laboratory to do any of these types of studies. They often are best done locally. This is just a screenshot of recording myself using a personal health record on the web. And then you can't hear me, but I'm thinking aloud about what I'm doing, and all the screens are video recorded. And we may or may not also have an external camera view, but I won't get into that. What can we do? I'll show you with specific data we got from these studies, and at this point, I'm probably done well over 100 of them, is that we can predict errors, rectify them, and we do this using video coding. And the idea also can be extended. You can do a study that's laboratory-based, where you're recording everything. You have some doctors come in and try out the system, but you can continue doing it in the real-life setting, is assuming you have ethics approval, to see how whether what you predicted actually takes place when the system goes live. So this was a model that kind of grew out of practical work and doing consulting and other things, but it ties into some of the theoretical models I taught at the beginning. It's kind of an upside-down triangle. There's one we did that was on, we called it a cognitive socio-technical model. And this emerged as whenever I was called in to do consulting about why people didn't use the system, I always started at the bottom, where it was less wide open, and did a study or two of users interacting with the system. It could be electronic health system or decision support in isolation before moving on. And that on the left-hand side really corresponded to the idea of that model of the individual cognition, of cognition in the head, or the information processing model. And then what happens is you can then move, you can optimize the system at the level 1 for individual cognition, but you still have to go and then conduct studies at level 2. For example, if we optimize the user interface of the electronic record, when one person is using it alone in the office, that's fine. But what happens when we now introduce that system into a clinic? And that, to me, corresponded to the concept of the distributed cognition. So I never looked at those as mutual models, but at models at different levels. You can optimize the system at the level of distributed cognition, or I have labeled that as the level of users interacting with the system and environment to carry out a work task. Still have problems. People may not want to use it. And then that may lead you up to level 3, which is more socio-technical, I might say, but it's issues around the organization, other issues come into play in that. But generally, this upside-down triangle model has proved really useful, both as a kind of a model and a guideline for conducting studies. And on the right-hand side, I've listed some studies types that work well at each of the levels. So at the level 1, basic usability testing will often get you what's in the individual person's head using the system. Going up to level 2 on the right-hand side, what we call clinical simulations often get you that information. And then going up to level 3, we may have to do observation or naturalistic studies. So was a way of relating those models to something useful. Example of, I want to do, I always like to start with an example of the very first study we ever did using Think Aloud protocol and video recording, but this was actually back in the 90s, and it was looking at how effective was the interface and content of the decision support learning tool. And right from then, we started with how do we record video. Now it's a lot easier. You can just record screens. If you have a Mac, you can use QuickTime and record them. You can record even mobile screens now. Back then, we had video to computer converters, but it was the same data. We recorded the video interaction of what they're doing on the screen, and on the audio track was what they were thinking aloud using screen captures. And before I go into that example, what I've done more recently, this was from a 2019 paper, is put together all the different ways over the years that we were looking at analyzing video into one sort of a tree or taxonomy of codes. So on the left-hand side, and you'll see how this works in a minute, we have coding scheme, Some of the codes that we developed were about cognitive issues or cognitive aspects of interaction on the top left, and another subclass was about usability. And the cognitive ones at the top, you could break into one's codes, and the codes are on the leaves on the right-hand side. Codes when we're analyzing decision-making and healthcare IP, like are they choosing a diagnosis or an action? Codes dealing with reasoning, are they forming diagnostic hypotheses at any point in time? The usability codes, what we did was split them up into those 3 levels I just showed. Level 1 are basic human-computer interaction codes. So we have definitions of navigational issue, when someone has a problem navigating, someone has a font issue, a speed issue. Those are pretty elemental and more at the level 1 I showed you on the other slide. Level 2, we have sets of codes for analyzing. If we're analyzing how people use a system in the clinic, we may want to see how it affects workflow or integration into other systems, and we've developed codes for that. And at level 3, we also may have codes for things like if people are verbalizing issues around privacy or confidentiality, it's kind of the higher level code. So we put it all together into a massive coding scheme. But I'll show you from the very beginning, the simplest study we ever did, I think it was 1993. We gave a tool that was going to be used for teaching doctors and medical students at McGill about learning about heart disease. It was educational and decision support. And then we created what we call log files, where we transcribed what they were saying. And the numbers there actually linked to the video. I don't have it, so I can show you that, but the numbers on the transcript correspond to the video sequences. So the 2 are linked, the audio and the video. And you can see right from the log file alone, you get a nice description of the user interaction. On the video, you can see at 1 minute, 3 seconds, the person's looking nervous using the system. Then at 2 minutes, 27 seconds, they go to the guideline screen, and they're immediately the thinking aloud comment on the information being old. And in doing this type of study, I remember then all of the physicians that tried the system all said the same thing, ended at the same point. You can look at what they do as they interact with the system at a very fine-grained level. I'm doing studies now where we're collecting stats on how often users go into different parts of the interface. You can get very detailed stats. And then when they have a problem, like the user says, the user's comments on quotes, how do I fast forward? It was clear at that point that they didn't know how to navigate home. So according to that coding scheme I showed, that was one of the categories we had, navigation problem. So the coder can plug that in. We put that in at the code at that point. The part about this that's very useful is we can collect statistics on, for 10 users or 20 users, how many problems do they have? If they have navigational problems, exactly which point in the system interaction or interface does it occur? So the user goes on, says, is there any way out of this? The experimenter says you can kill it. Sorry, you told me that. The program actually crashed, and this was something that was going to be sent out, and we told them, don't send it out until you fix the bugs. And then while this rebooting, the user's going back to talking about the usefulness of the information not being very great because all the guidelines have changed the year before. This is so very typical of many, many studies we've done since then. Oh, and the user is turning his head sideways. It had some narration that said click on the option menu, but didn't know what the option menu was. So that was an understanding of icon problem. And then at the end, facetiously says, I had to get out the owner's manual, but it came with no online help. So this is our very first example. When we did this, we knew this was really a useful and powerful method for collecting information. And that one, I would say, corresponds to that level 1 or the human information processor model. But having done that, we began to be interested more in cognitive aspects of usability that have to do with interactions with others. So we can look at reasoning or decision-making or interaction at the individual level, but we can also start moving up the ladder to the group level, the distributed cognition, where there's more than one person or system. And the purpose here was to try to integrate cognitive aspects with aspects of more traditional usability. So that in our model, upside-down triangle model, is moving up to the level 2. The previous example, I think, was a good one of level 1, looking at examining an individual user interacting with a system in isolation. But in the real world, often the system is used in the clinic or with patients. So the argument was that would be the level of distributed cognition. So we did a whole series of studies looking at that. And again, some of these methods are coming back in a number of new studies we're doing currently. But I always like to show where we came from on this and where we were going. And this was a whole set of studies on the impact of decision-making and knowledge organization, examining the transition from going from paper records to electronic medical records, and looking at how this occurred in practice, and also looking at the new part to this set of studies was what was the impact of the system on the interaction with the patients, and was there a methodological way of looking at this? So again, that sort of started thinking about the distributed cognition model, and this sort of spawned a lot of research on what we call the doctor-patient computer interaction, a three-way interaction I'll talk about. And this was our first studies moving away from the study of an individual human-computer interaction and decision-making to more collaborative. And if you're recording the interaction, we can record the screens on the computer, but we move away from think aloud, because if we're recording the doctor using the computer, interviewing the patient, we can't instruct the doctor to think aloud, because that would be very confusing if they're thinking aloud and interviewing. So it got into some other methods from linguistics and cognitive psychology, looking at analyzing dialogue or dialogue analysis or discourse analysis. And again, developing new coding schemes for looking at that interaction. And some of you recognize this was from some of the studies we did then, and I'll talk about what we're doing now with this, but that it was an electronic health record that you would load on the computer, and the doctor would ask about the chief complaint, or would load the filter, and there were different categories on the screen that could click off or enter information. So it was an electronic health record that had a certain look and feel to it. It was based on what we call the paper scroll metaphor. But at any rate, the doctors in the clinic were all given a laptop with the system, hadn't used the system before, were moving from paper to the system, and we recorded many things. We recorded their progress in learning how to use it. We did analysis of the learning curves, how long it took them to learn how to use it, and also usability testing, what problems they had. But then, and what I'll show, I wanted to really focus on the studies where we started recording the subjects, the doctors, using the system while interviewing what was called the simulated patient, someone playing the role of a patient. And what we found when physicians interviewed the simulation patient while using the EMR was a lot of interesting things. We recorded all of this. And we found that exposure to the system immediately affected the physician information gathering approaches, and I'll talk about this. And that ultimately affected their reasoning strategies. And it's interesting because I'm currently working on a project, I think with some of you may be on this call. We're doing something with the colleagues at Ottawa, where we're actually finding the same thing many years later. So what do I mean by this? Well, at the time we were working in a lab that was a lab for medical education, and one of the things that came out of that lab was that how students and clinicians reason and the reasoning patterns at different levels of expertise. So the proper one is what's called forward reasoning, where if you're working without any tool, you're probably going to ask questions, move forward towards a number of hypotheses, diagnostic ones. So in video recording the users learning how to use the system, they often went to the reasoning pattern that's below called backward reasoning, where they work backwards from information on the screen or diagnostic hypotheses to get and then ask about the patient data. So that's actually suboptimal. So we saw some examples of experts changing their reasoning pattern to something that was less than expert, at least for a period where they were learning to adapt to the system. And this is something very similar we're finding with the current project. When we analyzed the interaction, this time we're analyzing at the video interaction, the log file at a higher level, granular level. We're not analyzing every mouse click like I did on the first example. We're analyzing the sequence of activities at different times in that video. So in this one, we saw that when the doctor, this was from a doctor who learned how to interact with the system over 6 months. They were going to go into the system and jump right into that electronic system, but decided at 3 minutes, 55 seconds to stop and instead write notes on paper. And then went into the system after about 9 minutes. That was 9 minutes, 21 seconds. Chooses a clinical template and then went into what we call screen-driven behavior. What do we mean by that? Well, if we go back to the actual screen, what happened was when they did screen-driven behavior, they just started asking questions based on the order of information on the screen. And this was actually one of the reasons why they kind of went from a more expert reasoning pattern, at least temporarily, to something that was less than expert. It wasn't their normal way of doing it. The system had subtly guided what they were doing, what they were asking, which ultimately affected how they were reasoning as well. So it was the first demonstration of how even simply ordering information on the screen could have a profound impact on how they deal with cases. And I would say when watching the subjects, when they initially started using the system, we were surprised that some highly expert physicians seemed to take a very long time to get to a diagnosis while they were mostly managing the screen. And in subsequent studies, we found different styles. When they were with the patient, some doctors micromanaged the screen, and they weren't really listening to the patient. We could pick this up from the video. While other doctors took the approach of, I won't use the computer while I'm interviewing, I may take notes on paper, write stuff down, and then when the patient's gone, go into the computer system. So this got into studies on things like how do you cope with the information on the computer while you're also coping with the information from the patient. So in analyzing this, again, we put the lens of cognitive science on it as an example of distributed cognition, that in this interaction, the cognition is really distributed across 2 individuals, computer system, and some representations. And this framework kind of came out of a book in 1995 by Hutchins called Cognition in the Wild, where he studied how decisions were made on, it was military aircraft carriers, saying you couldn't understand decisions by looking at one person individually. In this case, we said cognition is distributed during the doctor-patient computer interaction or anything clinical where you have more than one person. And from the human factors literature, the collection of actors, systems, and the environmental setting in which they are situated is referred to as the functional system. As I said, previously this had been studied in areas like aviation, air traffic control. Also gets very much into the area known as situational awareness, fits in this. So from subsequent examples, this was a study we did later. We actually looked at dialogue analysis. This was, again, it's like a log file of what they were doing on the computer, but this is the doctor using the computer while they're interviewing a patient. So you can see, can get somewhat cognitively taxing for the doctor, because on the left-hand side, there's a dialogue going on between the doctor and the patient about what they're eating for breakfast. I think it is croissants, so I think they have diabetes in this example. On the right-hand side, at the same time, the doctor is essentially having a dialogue with the computer system and having to enter information about medications at the same time. So it's essentially carrying on two different discourses or conversations. And I know physicians cope with this in many ways. My family doctor essentially doesn't use the computer while he's interviewing me unless he's looking up a chart. But there were different styles in coping with this. And what are we coping with? Well, we're essentially coping with something called cognitive overload, or the potential for that. So in studying this, another sort of formalism from distributed cognition was that you would create circles for different what we call agents. And an agent could be a human or a system. So the doctor here, from the arrows, is interacting back and forth with the patient. But at the same time, the doctor is interacting back and forth with the computer system, or the EMR. And in some cases, the arrow back to the patient was for a scenario where the computer screen was also being displayed by the patient. But then again, we can see what else they're using. On the left-hand side, we can see what they're using, what external representations, paper notes, reports. If we get into modeling a clinic, we'll have more actors and agents, but it's the same idea. So this is the idea. If you want to represent or study what's going on, we need a view of what's going on as a distributed cognition process. So where did that lead since then? Well, studying virtual care using a distributed cognitive approach. So I'm working on a number of virtual care studies now, some in medical education and other areas. And this is studying, now we've moved from the doctor using the computer with a patient in the room, which was often very taxing for the clinician, to now in some cases, especially since COVID, doing all this remotely, where the doctor's using the electronic medical record, but it's virtual, it's on the computer screen, while on the computer screen as well on Zoom, and maybe a patient located somewhere else. So what can we do to assess how, for example, we could optimize the interaction? We can assess the same way usability problems, impact on workflow, the impact of going virtual. And in one project we did, this was before COVID, it was a few years ago with the health authority, we also came up with ways of evaluating whether virtual care technologies supported or not the doctor-patient interaction. Now we've moved to virtually. So we see now we've added to that functional system another technology, which is the actual video conferencing, which could be Zoom or any other technology. So you can see how we can scale up the way of looking at things as distributed cognition. Okay, so a little bit more detail on how we can analyze this. And what we've developed a lot, I showed in the beginning that tree of different codes of coding categories. And as some of you know, through coding, it could be coding interviews, qualitative coding. There are many perspectives on developing approaches to coding. Some are based on having a prior coding scheme, like the one I showed that was that tree diagram. And other times people will use an approach called grounded theory, where they go in without any presupposed categories and just, as I say, let the data talk for itself in coding. And what we found most practical is that we can combine the two and have categories that are useful for looking at human-computer interaction, gives you a lens, but also being open to adding new categories as they come up that you have not presupposed. So I'll send these slides out if you're interested. We've got a sequence of 3 papers on this. But just to give you an example, is we usually develop a coding category dictionary that help you identify problems or safety issues or impact of systems on clinician decision-making or workflow. So this was a kind of the coding dictionary we made from a number of studies where you have the codes from that tree diagram defined, like navigation. We have that's the first one. The code definition is we code for that. If it appears there's a problem, the user has a problem moving through the system. And then we usually have an example to show the coder if they're looking at a new set. A good example, a patient can't backtrack to a screen with the allergy information in the electronic health record. We've seen lots of examples of these. So we have many examples of each of these codes. One of my favorites is consistency. Coded when there's something inconsistent in the system that the user's picking up or not picking up. And in one system we evaluated, it was a pan-Canadian public health surveillance system that had 4 components, and the day, month, and year wasn't the same in 2 of the components. And the developers hadn't picked that off, and doing a number of different cognitive studies, we found that people were a bit frustrated with that, and there was an obvious error. So there's a lot of different codes we can define. This is the categories that can help us look at the data. One of the areas that we extended this into was relating usability with system safety. A lot of people were saying, you know, unusable systems can kill and all that kind of thing. And while we weren't interested in making those statements, we were just more interested in looking at the relation between usability problems and system safety using this coding approach and coming up with ways to improve systems. So cognitive studies, again, can be used to connect usability with system safety and error. And we found there's obviously a close relation between serious usability problems and errors that users will make in healthcare, medicine, nursing, any of it. And that the idea was to quantify and statistically analyze it. So again, this was an example of another think aloud study where we use that coding scheme and we can pull from different parts of it. This is the user is given instruction to enter a medication into electronic health record. There's like a pick list of options. Darvon, the user says, I'm waiting for the screen to appear, but I'm not sure if what I clicked on is correct. This was coded as a meaning of icon problem. And then there was a response time issue with speed. And then the participant starts typing in the medication in the text box. Then the system responds with medications with the letter D after about a minute. And then the user notices that the screen is quite small, which we call the font problem, coded as in bold. And then right then and there makes an error and enters a medication that's next to it, but not the right medication. And in this case, didn't even know that they had done that. So we can actually look at things like how big should the font be, or what happens if the names are close to each other. So we then looked at all previous data to look at how usability related to safety, and there were hundreds of examples. Display visibility problems that we had coded for when user didn't understand that they have to scroll through a menu to get the right dose. This often occurred on handheld prescription writing applications, which would pop up a default at the top for dose, and then people would think that's the recommended one, but they didn't realize they could scroll. I mentioned navigation problem. Something as critical as not being able to find the allergy tab could result in a death of the patient, and we have seen examples of that. Consistency problems and meaning of labels. One of my favorite was a study we did where we were looking at the multiple levels of interaction for a alerting system embedded in the EHR, and alerts popped up and no one clicked on them because they didn't know what the label meant. It was BPA, best practice advisory. So it was as simple as, some of these issues are very simple to solve, other ones around workflow aren't, but we look at all levels. I'll just give one other example about relating usability to safety. We were interested when people started using mobile devices a lot, doing studies around the impact of shrinking things on the screen And mobile devices are great for simple things, but everyone at the time was talking about that mobile devices would be full interfaces to complex software like electronic health records, which hasn't really occurred very well. I mean, on tablets, we have interfaces to Cerner and Epic, but still an issue not having a full interaction. But at the time, what we looked at were prescription writing programs, which are more complicated than the typical health app, but not full EHR. And we thought if we shrunk the screen, it would be a good area to collect data on how people make errors. So we wanted to assess if the application, and it was a very common prescription writing software application that later on we found out was used by hundreds of thousands of doctors in the US daily. And at least while we were learning to use it, could we assess if the application induced errors? And this was what Dr. Bricky talks about as technology-induced errors, that the system itself might not have an error in it, so it's not a software bug, but if you're in a hurry or the screen is small, could it lead you to an error? So again, it was a prescription writing software application, had thousands of medications. What did it do? Allowed you to enter store medications, print them out, and process them. So 10 physicians who had not used the program before but used mobile were recruited. They received training on use of the software about as much as you would normally get, which was clicking around, as there was no training program on it for anyone. And then they were asked at different levels. One was to enter medications from a list as accurately as possible. And we also had those scenarios where they did a clinical scenario with someone playing a patient. And in the first case, they were asked to think aloud, all the screens were recorded. So again, we got data that was detailed about what they were saying and what they were clicking on at the same time. So the level of, at the beginning, the subject is saying, amoxicillin, 250 capsules by mouth twice a day. And then in gray there is what's annotation about that particular part of the interaction, what they entered. And then the user says, oh, wait, I think because it was so small, he wasn't used to clicking, he just got 6 extra tablets. And that was coded as an error. Oh, that should have been a slip. The slip was an error that they fixed. So that one he caught. But at the same time, there was another error that he entered called PID instead of QAD. That's just the scheduling of the med. But at any rate, what we did in analyzing it was go through and have a run analysis for everywhere where there was a usability problem like this. And then a second code or coding it independently whenever there was a medication a mistake or error. And then lo and behold, we found there was a high correlation between certain types of usability problems and specific errors. So what did we find? The transcripts were coded to identify usability error problems and medication. We had 73 usability problems and 27 errors. Now, what we found was that 37% of the usability problems had an error associated, but every time we had an error, we found one or more COVID usability problems. So we thought, can we predict how often a usability problem will occur? It was a small pilot study with about 10 people. I'll talk about how we scaled it up using simulations. But just the data from it, we could even go fine-grain and look at the type of usability problem. In bold there on the right, 2 were highly correlated with errors. One was wherever we had coded display visibility problem, something wasn't visible, had a high percent of times there was a problem associated with that part of the screen, at least while we were learning how to use it. Same with data entry. So we were looking at the columns there of how often use a particular type of usability problem had an error of some kind associated with it. So display visibility, 16 out of the 19 times they had that problem at the top row, there was some type of transcription or other error. So highly significant relation between certain types of usability issues and error. Slips versus mistakes. Half the time the errors were caught, and we coded that as slips using a terminology from Donald Norman did the cognitive studies, but we modified what we meant by slips as something that you catch. And mistakes were things that went into the database or got printed out that were actually wrong. And 50% of the errors were mistakes. So issues, while training, subjects didn't have expensive training on the application. However, at least during while they were first using it, they were making lots of mistakes. And presumably they would go into practice using it. Again, fast forward to a study I'm working on now, and we're looking like it may be that at least during the beginning of using a system, there's a lot of suboptimal behaviors. This was followed up with also moving up that ladder naturalistic studies, which also included some work we did on taking results from small-scale qualitative studies and using them as base parameters into computer simulations. And for this paper we did, it was what would we tell managers about safety of systems based on studies we have done. And what you can do is feed into the simulation. This was using Stellar simulation software, how often types of errors occur from the studies, and then scale it up to how many people will actually be using that software in a province or country, and then building in information about how long it takes for them to learn how to use it properly. In one of those simulations, I think we came up with over 100,000 errors a year, at least while people were learning how to use that software. So we were trying to go, how can we magnify the information? So what are the implications of all of the above I talked about? Well, implications for designing and testing information systems is that we need to test systems at multiple levels of cognition, from individual to distributed, and this is what we've been trying to achieve. And this led to some other work where we called one approach is called the safety net approach of testing systems before releasing them into clinics, hospitals, or live. And again, borrowing from some of the learnings we had, that you really need to look at multiple levels from individual interaction to distributed or group, using, again, multiple methods from the laboratory to the naturalistic. And this was from MedInfo paper 2017, where we argued for a layered safety net approach for testing systems before releasing them, starting with the system design at the top, going through some of this low-cost rapid usability testing, which can be done effectively with individual users taken aside, observing, recording them, coding it, error correcting, or optimization, then running clinical simulation where you might then extend it to, we've done this with simulated patients and digital patients and groups of users. Again, now correcting for things like impact of the system on workflow and inadvertent errors. And then in some studies before releasing the system, one project in particular at Mount Sinai, New York, we actually added a layer of nail-wide testing before releasing. It was an electronic record system with an alerting component in it. And lo and behold, if we did all those layers, by the time we release the system, there's a lot fewer user problems, a lot less issues with adoption of the system. So it was kind of developing this as a package. And just how is this work being used to prevent errors in usability? Well, as I mentioned, done a range of usability testing in clinical studies, feedback into improvement of software, the process of development of the software. And some people have said, well, you can't modify software once you've bought commercial, which isn't true, because we might spend several years customizing it and also providing training. So we've worked with organizations using some of the methods today I mentioned when they bought systems like Cerner and Epic. Essentially, some of this is really software testing, and we have applied it and recommend it be applied also for organizations or regions that we're going to select the computer system, saying, if you take the candidate systems and make them all be tested using this kind of rigorous approach before you buy them, have a lecture called Try It Before You Buy It, you might have a lot of useful input in figuring out what the best system is and what really works from the user's point of view, and also functionality. And also moving, well, as I said, can be moved to remote analysis over Zoom. So I'll just end with, I mentioned that book that we're just putting out. It will be out shortly. In the last chapter, I did something on looking forward directions for cognitive research and HCI, and I think there's going to be a resurgence of this on many areas. As an example, why, back to the beginning, cognitive approaches are needed. Well, one obviously is measuring cognitive load. We want to avoid overload or cognitive overload. And there are many lessons, much more advanced than in the healthcare field, as in the aerospace area, where design of cockpits, human factors engineers and cognitive psychologists have been involved in design of cockpits for decades now. But a lot less work done on designing the interfaces for things like electronic records in a way that don't overwhelm the users. So we want to look at what are the cognitive limits of users, and again, some of the cognitive methods are useful. If we're talking about removing human cognitive bias using technology, we have to look at that interaction. And again, it's a cognitive issue, because ultimately, if the decision maker is human, there may be cognitive bias. And if the decision maker is a machine, as many of you know, there's a whole literature appearing on data set bias. And that leads up to a point. I do another lecture on AI and human factors in the relation, but argument that we really need cognitive studies if we want to better integrate AI into human-in-the-loop decision-making. And despite all the buzz in AI, and I've been through several cycles of AI, previously in one of the other sort of heydays of AI, there was a lot of buzz, a lot of prototypes, a lot of pilots, but fewer of them got put into actual medical practice. And that's still actually the case. There's a lot of buzz with renewed emphasis on neural nets and deep learning, which is making a big comeback. But if we actually look at the number of applications in practice, there are not as many as we would think. And I've argued that we have to go back and look at this from a human and cognitive point of view. Why? Multimodal HCI, more and more systems will have speech, gesture, haptic interfaces, and that gets into the cognitive area of perceptual studies, and even things about like studies of how to switch attention and support multitasking. Development of decision support to integrate in the workflow, doing things like reducing the effects of some of you may have heard of something called alert fatigue, where if too many alerts and reminders come up, doctors and nurses or clinicians or pharmacists simply start ignoring them to the peril of safety. And I think I saw Joost Ops on here, who's done work on a lot on alert fatigue. And to study alert fatigue is really studying, it's beyond the technology, it's a human cognition issue. Why do people ignore things after a certain period? And how can we optimize the alerts and not overload the user? Safety informatics area that is what Ricky's worked a lot on, reduction of human error and error when humans work with machine as well. This ironically being left quite open, despite, as I said, all the new buzz on AI. Patient-centered design, moving to consider patient and lay person cognitive capabilities as the technology for health we do moves not only for clinicians and health professionals, but now everyone's using apps and devices at home. And again, to develop those in a meaningful way, we'll have we will need a better understanding of how people understand and use information. This is a lead-in to another area that will become larger, is the virtual and home care, integrating technology into the home obviously is going to require understanding of patient cognition. And on the right, we built a smart home lab down the hall, and this demonstrating a smart TV that could be used, for example, presenting information to elderly patients about taking medication. There's a smart fridge, a smart bed. So a whole other area where usability, HCI, and cognition all come to play. And last but not least, just advances in human-computer interaction study designs, particularly as we move from looking over time from individual users to users working collectively in a distributed cognition model or naturalistic studies. And I have found that we can borrow in health informatics from fields like computer science and psychology, but then given the complexity of healthcare, when we apply them, we often have new insights that go back into the base fields. And there's a term that came up a while back, I think IBM brought about cognitive computing. And the idea here is that's having a bit of a resurgence. Before we called things cognitive emulation, but if we've looked into this, it's not really being well defined, and it's probably time to look at what we really mean by cognitive computing. This is another interesting area. So, in conclusion, what is the role of, what is the role of cognitive research in health informatics? In this lecture, it's been argued cognitive research is needed to build better and more usable and optimized systems. I should have put optimize as well. And with the advent of more complex systems, user interactions in AI, this need will accelerate. No system, no matter how smart it is just used in a vacuum. And this is often forgotten, and the emphasis has been on accuracy of the system, not the man-machine or human-machine system in a distributed context. So I think frameworks like the distributed cognition will become more important. On my last point, frameworks and methods to address this need to be disseminated. And as I mentioned, if this is of interest, we have a second edition of the book coming out on human-computer interaction and healthcare, where we're trying to bring a focus on this out with current trends. Okay, thanks.
Thank you.